You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from the Heart.org Medscape Cardiology, and this is This Week in Cardiology for July 19th, 2024. This week, we'll talk about the vulnerable plaque, the scientific method in prominent journals, industry payments to trainees, tirzepatide or semaglutide, trial interpretation, the ITT versus on-treatment analyses, and pulse field ablation. The first topic is about finding the vulnerable plaque with PET imaging. More than 30 years ago, I was taught, first at Hartford Hospital and then in Indiana, that most MIs occur in young, immature plaques that were not severely stenosed. For whatever reason, possibly no reason, a non-stenotic plaque can rupture and cause a clot and an MI. This mostly ignored lesson is why negative stress tests don't exclude the chance of having an MI. It's why bypass and PCI of stable stenotic lesions don't reduce MI or death. Here's the problem. Over the years and decades since this core knowledge has been known, many investigators have tried to reach the twin pinnacles of modern cardiology, and that is the identification of vulnerable plaque and effective treatments of that vulnerable plaque. Jack has published a study from the famous Edinburgh group led by Professor David Newby that has led to headlines in the news such as, quote, PET imaging finds vulnerable plaques that cause MI, end quote. Gosh, if that were true, it would be amazing. We could all buy more PET imaging machines, image patients, and shred the incidence of heart disease. But, if the identification treatment of vulnerable plaques is a marathon, the study presented in Jack might be the first kilometer. Or, it's possible you might even be running on the wrong marathon course. Before I give you the neutral Martian, non-PET imaging expert take on this evidence, let me first set out the most likely possibility of heart attacks and likely most human disease is, wait for it, sit down, slow the bike. The most likely cause of most terrible events in healthcare is chance. Many of you know the term stochastic, but I have come to believe that stochastic is the explanation of many of the conditions we treat. Now, my understanding of things that are stochastic are that they're ultimately random events, although there may be a probability effect. For instance, smokers are more likely to have an MI, but when or if an MI occurs is random. Or, for instance, radiation exposure from cardiac procedures increases the risk of having cancer, but whether a cancer occurs in a cardiologist is random. If you studied 1,000 cardiologists and 1,000 internists, maybe slightly more cardiologists might have a cancer, but whether a cardiologist gets cancer is still random. It's stochastic. And I believe that is the story with vulnerable plaques. Stochastic could be translated into shit happens. Now to the Jack study. This was a secondary analysis of a prospective study of F-fluoride PET imaging in more than 2,600 patients who had had an MI and also had multivessel coronary disease. Now, the first study was published in JAMA Cardiology last year in 2023. The Jack paper, first author Kang-Ling Wang, aimed to test whether vessel-level coronary plaque activity is associated with vessel-level MI. It's a great concept, right? You do a PET scan. If there's increased uptake in a vessel, you will know that that vessel is kind of hot and perhaps could be treated. Now, treated with what exactly is a question, but forget the treatment because we aren't close to answering that. Let's just see if we can use PET imaging to detect an at-risk artery. So here were the top-line results. Over 2 years of follow-up, an MI occurred in 4% of vessels that had increased uptake and 2% of vessels without increased uptake, and that hazard ratio was 2.08, and confidence intervals were significant, and the p-value was 0.01. The authors then tested the association in vessels that were treated with revascularization versus those not treated with revascularization, and lo and behold, those who were treated with revascularization did not have an association, but untreated vessels did have a positive association. Now, the authors also noted that increased coronary plaque activity in multiple vessels was associated with an increased patient-level risk of cardiac death and MI. The hazard ratio there was 2.4. All right, so my comments. When I read this study and the supportive editorial that was senior authored by Dr. Fuster himself, I thought, gosh, this is amazing. The Edinburgh team is onto something. Vulnerable plaques detected non-invasively is really something big. Well, there are problems. First, this vessel-level analysis is a secondary analysis of an initially negative cohort study. Now, it's not even an RCT. Journalist Sue Hughes quoted senior author Dr. David Newby saying, quote, "This is the first multi-center randomized trial to show PET can be used to identify vulnerable plaques." But I don't think that is exactly right, because the original analysis that I'll link to is in JAMA Cardiology, first author Alistair Moss. This is a cohort study of patients post-MI who had multivessel disease. That cohort study had a primary endpoint of CV death, MI, and unplanned revascularization. Of the 2,600 patients screened, about 1,000, less than half, were eligible, and 712 patients had imaging. The rate of the primary endpoint, that three-component primary endpoint, did not differ in those with low or high coronary plaque activity as measured by the fluoride PET. The primary endpoint was non-significant. And you don't have to believe me. Here is the first line of the author's conclusions in that JAMA Cardiology paper. Quote, "In this cohort study of patients with recent MI, coronary atherosclerotic plaque activity was not associated with the primary composite endpoint." Now, you might ask, did the authors say, gosh, this did not work? Well, no, they did not say that exactly. Instead, they looked at a secondary endpoint. They looked at the composite of cardiac death, or MI. And this was indeed higher in the high plaque burden, 1.82 hazard ratio with positive confidence intervals. The authors hang a lot of emphasis on that endpoint because CV death and MI was supposed to be the primary endpoint, but was changed to CV death, MI, and unplanned revascularization because of lower than expected events. Now, you all, I'm just a neutral Martian here, but if you don't like your more specific endpoint because events are low and you fear your study will have no difference, and then you change your endpoint to capture more events, and then that endpoint with more events is negative, you can't go back and emphasize your first endpoint after you know the results. Okay, second problem with this. If your original study with the primary endpoint is non-significant, it's highly dubious to go back into the data and publish a positive secondary analysis. Third problem. Even if you ignore the issue of going back into a non-significant original analysis to find a positive secondary finding, the difference in the vessel-specific PET study was 4% versus 2%. That means that 96% of vessels with high uptake did not have a future event. Fourth problem. Even if you ignore the first three problems and you believe PET identifies vulnerable vessels or vulnerable plaques or vulnerable patients, how else do you treat these patients over and above lifestyle changes and stents? So I don't know the answer. I'm sorry to say that the holy grail of cardiology, the identification of and treatment of vulnerable plaques, remains totally 100% elusive. But you would not realize that from reading our most important cardiology journal, and I think that is a problem. All right, speaking of problems, let's talk about industry payments to cardiology fellows. The team of Sanket Dhruva and Rita Redberg have a new research letter out in JAMA Internal Medicine looking at industry payments to cardiology fellows. Now, before I tell you about this study, I recall my training at Indiana many years ago. Industry was everywhere. Thursday Echo Conference, Friday Cath Conference were always sponsored by a drug or device company. There were trips to pacing company offices for education, and in clinic there was often food laid out by industry. I'm not sure we were outliers, but when I came to private practice, having industry people around felt totally normal. The authors of this new paper write in their second sentence that, quote, payments to trainees merit scrutiny because these payments may be formative on future practice, end quote. Of course these payments are formative. That is the point. The study attempted to quantify industry payments to fellows and then measure the association of these payments to receiving future payments. Now, these were all non-research related payments. The study sample was slightly more than 5,000 cardiology fellows, nearly half were procedural, 21% female. During the year before graduation, 80% of procedural fellows and 67% of non-procedural fellows received payments from industry. The median amount was $1,800 in the procedure group versus only $200 in the non-procedural group. 3 years after fellowship, 96% of the cardiologists in procedural fields and 81% in the non-procedural fields had received industry payments. Physicians who received general payments in the year before their fellowship graduation were more likely to receive payments after graduation. The hazard ratio was 2.12, so they were double more likely to receive industry payments as practicing physicians. Docs in procedural fields were more likely than docs in non-procedural fields to receive any payments. That hazard ratio was also 2.2. And if the amount of money received in fellowship was more than $5,000, then the hazard ratio for receiving payments in practice was 3.3 or 3x. Now, my comments. I commend the authors for doing this work. As I have said many times in this podcast, I am not against innovation, nor am I against a profit motive for industry innovation. We have better tools, devices, and drugs today because of profit motive. But there should be strong barriers between doctors and industry. When a device company spends money taking fellows out to dinner or sending them to meetings, that money has a specific goal. Industry might say it is for education, but is actually 95% for marketing. If this is done on a grand scale, industry can help establish therapeutic fashions. For instance, imagine a world where a specific company, say one who makes a left atrial appendage occlusion device or an LV support device, takes care of fellows in many different programs. Now when the fellows get out, nearly everyone has an experience with the company and its device. The use of these devices is now normal. Marketing and fear of missing out is not the only way therapeutic fashions can occur, but it is a big contributor. Now, a specific word here about my field of electrophysiology. It saddens me greatly that so much of our education in EP is done via industry. At HRS, I went to a lunch symposium sponsored by industry to hear a lecture from a friend. I stayed for the other 3 lectures, and it was shocking how biased the presentations were regarding the company's product. I didn't tweet it or write about it, but perhaps I should have. Some of the other lectures were from key opinion leaders, and hearing such biased presentations decreased my respect for them. I am sorry, but industry payments to doctors is often unseemly. It's unprofessional in many cases. It should be possible to learn new techniques without taking money from industry. With the advent of social media, I learned conduction system pacing, that is his bundle pacing and left bundle area pacing, without taking money from industry. When you learn from industry courses, you are being marketed to, period. All right, next topic is tirzepatide versus semaglutide. The SELECT trial of semaglutide in patients with obesity and established atherosclerotic vascular disease found that semaglutide reduced hard cardiovascular outcomes by 20%. Notably, this was in addition to baseline therapy with statins. The SELECT trial makes semaglutide a disease-modifying drug in heart disease, and that is big. Now, the FLOW trial of semaglutide in patients with chronic kidney disease has helped confirm the disease-modifying properties of semaglutide. The FLOW trial studied 3,500 patients with diabetes and CKD, chronic kidney disease, and had as a primary endpoint a composite of kidney outcomes one of which was cardiovascular death. And in flow, semaglutide over placebo reduced the composite outcome by 24%. This included a statistically significant 29% lower rate of CV death. Again, 80% of these patients were already on lipid-lowering agents. Now, how semaglutide reduces outcomes is a major question. Surely, a large driver of this benefit is weight loss, but there have been arguments made that some of the benefit is independent of weight loss. The mechanism question is important because tirzepatide, which has a dual GLP-1A and gastric inhibitory polypeptide action, also induces weight loss, but has not yet had a cardiovascular outcomes trial finished. So the notion of class effect here is a huge one. Should we assume that tirzepatide has the same effects on cardiovascular outcomes as semaglutide? JAMA Internal Medicine has published a comparative observation study of tirzepatide and semaglutide looking at the degree of weight loss. This was a cohort study of 18,000 propensity-matched patients who initiated either tirzepatide or semaglutide. The first author, Patricia Rodriguez, PhD, and colleagues, they used electronic health records data from multiple U.S. healthcare systems. They had a total sample size of 41,000 patients, about a quarter on tirzepatide and 75% on semaglutide. And before matching, patients taking tirzepatide were slightly younger, more often female, and more often had a college education. But of course, propensity matching matches these patients, but we've talked about how it's not perfect matching. In short, the top-line results are that patients on tirzepatide had more weight loss. For patients who lost greater than 5% of body weight, the hazard ratio was 1.76, so 76% more likely to lose more than 5%. Patients were 2.5 times more likely to lose 10% on tirzepatide, and it was 3x more likely to lose 15% of their body weight on tirzepatide. The GI side effects were similar. My comments. The authors strengthened this observational study by confirming these results with sensitivity analysis. One of the sensitivity analysis is using inverse probability weighting, and the results were similar. Still, tirzepatide induced more weight loss. These results also mirror the findings from clinical trials, although the two drugs have not been compared head-to-head in a single clinical trial. In the Surmont studies of tirzepatide versus placebo, weight loss there was greater than weight loss in the semaglutide versus placebo group seen in the STEP trials. The authors tell us that there is actually a Surmont 5 trial comparing tirzepatide versus semaglutide, but again, this is only looking at the amount of weight loss. If you add this observational data to the trials, I suspect that tirzepatide does indeed induce more weight loss than semaglutide, but does that mean it has the same cardiovascular outcomes data as semaglutide? I looked, but I could not find any cardiovascular outcomes trials for tirzepatide. There is the SURPASS CVOT trial of tirzepatide versus liraglutide looking at major adverse cardiac outcomes, but it is not yet completed. Otherwise, we don't have CV outcomes data with tirzepatide. Tirzepatide has a GLP-1 agonist mechanism of action, and so it is likely that it also induces the same CV outcomes as semaglutide, but we don't know for sure. And gosh, it would be nice to know it was a class effect. We have cardiovascular outcomes trial for multiple beta blockers, multiple RAS inhibitors, multiple MRA drugs, and SGLT2 inhibitor drugs, and I feel like we ought to have them for GLP-1 drugs in obesity. All right, let's talk about colchicine and trial interpretation in the Lancet. Now, here's the idea, right? Inflammation plays a role in causing vascular events. Non-cardiometabolic stroke or vascular stroke is a common manifestation of cardiovascular disease. Would an inflammation blocker, like colchicine, reduce the risk of recurrent vascular stroke? The first reason to discuss the CONVINCE trial is to emphasize to a cardiology audience that many, if not most, strokes are not cardioembolic or related to AFib. Many strokes are due to small vessel atherosclerosis. The second reason to discuss the CONVINCE trial of colchicine versus placebo in patients with a TIA or vascular stroke is to discuss trial interpretation. Dr. David Brown alerted me to this issue via Twitter or X. More than 3,000 patients were randomized in CONVINCE after a high-risk TIA or vascular stroke to either colchicine or placebo. The primary endpoint was a composite of first, fatal or non-fatal recurrent ischemic stroke, MI, cardiac arrest, or hospital admission for unstable angina. Basically, it was a broad MACE endpoint. Here were the results. A primary endpoint occurred in 9.8% of patients on colchicine versus 11.7% on placebo. This corresponded to a 3.32 versus 3.92 event per 100 patient years. It resulted in a hazard ratio of 0.84 with confidence intervals that went from 0.68 to 1.05, p-value equals 0.12, which is clearly non-significant, right? The upper bound is more than 1, the p-value is well more than 0.05, but here was the conclusion. Although no statistically significant benefit was observed on the primary intention to treat analysis, the findings provide new evidence supporting the rationale for anti-inflammatory therapy in further randomized trials. Or comments. This is strange. I thought we had the p-threshold of 0.05, and that finding is way over that. The way that the authors justified this language, I think, is that they used the on-treatment analysis. On-treatment meaning the patients who actually received colchicine. And here were the results of that. It was 8% versus 11.7%, and that hazard ratio was 0.796. Notice the 3 decimals. And the confidence intervals went from 0.63 to 0.9992. Notice the 4 decimals. This is funny, isn't it? They carried a hazard ratio out to 3 decimals and the upper bound of the confidence intervals to 4 decimals. The thing is that they had planned for colchicine discontinuation of 15%, but they had an observed discontinuation rate of 20.5%. The authors also emphasized that colchicine reduced the CRP levels. I think the issue here is that you cannot use an on-treatment analysis like this. You have to use the intention to treat to preserve randomization. People who stop taking a drug or a treatment or don't take the drug are likely to be different from those who took the drug. On-treatment analyses are fine to do. They teach you things for maybe future study, but I don't think this particular on-treatment analysis with an upper bound of 0.999 lends much confidence in the anti-inflammatory theory of treating vascular stroke. Now, another reason to highlight this paper is that I find it very interesting that the trialists are spinning results of a non-significant trial, even though the trial is not sponsored by industry and colchicine is super inexpensive. I think this speaks to an intellectual, not financial bias. Scientists, it seems, like to find positive results, but I wish it were not that way, right? I wish scientists simply like to do experiments and interpret them more neutrally and more skeptically. All right, speaking of skeptical, let's talk about pulse field ablation. I wrote a column on the outsized enthusiasm for pulsed field ablation for AF among U.S. electrophysiologists. It's up on the heart.org, and it's short. It's easy to read. It really surprises me how much marketing and the fear of missing out affects the brains of U.S. EP doctors. Our enthusiasm for first-generation PFA systems is remarkable, and it's inconsistent with the empirical evidence. The empirical evidence finds no difference in efficacy, no difference in safety, many-fold higher cost of PFA versus thermal systems, and really, despite the rumors of speed, the empirical evidence does not confirm that PFA is that much faster than thermal ablation. Sadly, you cannot be a top person in EP unless you are adopting first-generation PFA systems. I'm going to link to my short piece, and I hope you read it and comment on it. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please take the time to give us a rating or write us a brief review. If you have something to add or disagree with something I say, go to theheart.org, write a comment. I learned from these. Until next week, this is John Mandrola from theheart.org, Medscape Cardiology.
You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.